Hey folks, welcome back to the MBG Clinical Course Seminar Series. It's Friday, November 10th, 2023. This is week 17 of the series, and we're happy to welcome back Dr. Austin Larson, who's going to talk to us about mitochondrial disorders. This is the second in that part of the series. As always, questions can be put in the chat or saved to the end. You can find this recorded, archived at the simd.org website, and the CME code will be put in the chat too. Sarah's going to pop that in there, and I can refresh it periodically as people get on. So with that, Austin, I'm going to give it over to you.
Thank you, Pete. And thank you all for being here. This is something that I've really enjoyed over the last several years. And I'm happy to be invited back and to be talking with you about one of my favorite subjects. So my goal here is to, first of all, disclosures. So this is CME, so financial disclosures, mainly related to being a site PI for industry-sponsored clinical trials, board membership, and a little bit of consulting as well. So my goal here is to talk about some aspects of mitochondrial disease that Dr. Falk did not cover in her talk. So her talk was a great overview of mitochondrial physiology and pathophysiology, biomarkers, diagnostic strategies, some therapeutic strategies, reproductive technologies, things like that. So my goal is going to be much more focused on the clinical experience of treating patients with mitochondrial disease, and roughly split into two halves. So the first half is going to be a discussion of the clinical correlates of mtDNA related diseases, and then the second half is going to be a discussion of the clinical correlates of nuclear DNA related mitochondrial disease. This is a huge topic, right? There are hundreds of different mechanisms of mitochondrial disease. So a really extensive survey of that topic would be not at the right level for this lecture series, and way too long. So I have done a lot of editorializing here and focusing on specific phenotypes that are unique, identifiable in the clinic, diagnoses that have management implications in particular. So this is really just my opinion of mitochondrial diseases that are kind of high yield, but also just kind of really interesting and instructive about underlying mechanisms. So I want to start with a quite common mitochondrial phenotype, and one that I think a lot of folks on this call have probably already come across in the clinic, and that is Lee syndrome. So Lee syndrome, importantly, is a clinical descriptor, and it is a description of a patient that meets the following criteria. They have some neurologic symptom, typically developmental delay or neurologic regression, potentially apnea, dystonia. They have typical findings on brain MRI. When we say typical findings, what we're talking about are bilateral, deep gray matter tissue injury. That's often seen as restricted diffusion. Depending on the timing since the injury, it may show up as T2 hyperintensity, or later on in the progression, it may show up as atrophy in those areas. And in addition to both a symptom and specific MRI findings, the patient, in order to be considered someone with Lee syndrome, has to have clear genetic or biochemical evidence of mitochondrial disease. So this is a phenotype that is a common pathway of a lot of different mechanisms of mitochondrial disease. So at least 75 I think over 100 now, different genetic etiologies, both within nuclear and mitochondrial DNA. Patients with Lee syndrome typically, but not always, have onset early in childhood and have a progressive course. So as we care for more and more patients with Lee syndrome, we do see a lot of variance on this. So occasionally we see someone with their initial brain injury much later in life. We also will see patients that have an initial really significant brain injury, but then don't have much of a progressive course. They seem to have a really static course with symptoms related to that one single episode of injury. So there are a lot of variations on this, but these are the main descriptors that are associated with the phenotype. So to dive into a little bit more detail about what exactly is the characteristic brain MRI appearance, it is, again, symmetrical high T2 signal in what we think of as energy intensive regions. That includes the brainstem, the periaqueductal gray, the medulla, the midbrain, including the thalamus, the basal ganglia, and the dentate nuclei, which are the deep gray matter of the cerebellum. The neurologic symptoms that are apparent in clinic are directly related to the area of tissue injury that you can see on brain MRI. So a patient with really significant injury in the medulla or the periaqueductal gray might have central apnea as a really prominent symptom. A different patient that has extensive basal ganglia injury might have dystonia as their most prominent symptom related to Lee syndrome. The MRI to some degree can help guide management. So for example, a patient who may not have a clinical history of central apnea, but has clear evidence of brain injury of the medulla or the brainstem, that's a patient that I would watch really closely on an ongoing basis, maybe get sleep studies regularly to look for central apnea. If you do have access to MRS in addition to MRI, then you may see evidence of increased lactate on the MRS as a correlate of mitochondrial dysfunction in the central nervous system. So the clinical features of Lee syndrome often, but not always, include initial symptoms in the first 2 years of life. The classic description of Lee syndrome includes progressive and fatal disease, but some patients have a pretty stable and static course after their initial presentation. And some only have very, very slow progression. Other patients have really rapid progression and proceeds to life-limiting symptoms within a few months after the initial symptoms become apparent. Again, like I mentioned earlier, developmental delay is quite a common symptom. Hypotonia, dystonia, ataxia if the cerebellum is affected. A significant fraction of patients have seizures, but probably fewer than you would expect. So that's not a really prominent aspect of Lee syndrome, though it certainly is present. Hyperreflexia for those patients that have damage to the pyramidal tracts, central apnea, dysphagia. There does seem to be really clear associations between the acute brain injuries and infectious illnesses. It's a little bit unclear what the mechanism of that correlation is. For a long time, we've talked about that being associated with catabolism and energetic stress within the CNS. But increasingly, there's a lot of discussion about more immunologic and inflammatory mechanisms. We know that there are mitochondrial biomarkers associated with viral illnesses and with sepsis. And so that's, I would say, an emerging area in terms of the the mechanisms of brain injury associated with Lee syndrome are those more immunologic mechanisms. So that's something to watch. The known genetic etiologies of Lee syndrome in the early days were primarily mitochondrial DNA, because that was the type of diagnostic testing that we had available in the early 90s. But then as we moved into the exome and genome era, we have started to characterize many, many genetic correlates of Lee syndrome that are associated with autosomal or X-linked genes. So these are a few examples of genetic correlates of Lee syndrome. So it includes almost all of the genes that contribute to the pyruvate dehydrogenase complex. Many, many genes associated with each of the complexes that participate in oxidative phosphorylation, CoQ10 synthesis, mitochondrial DNA maintenance, mitochondrial translation, and some other pathways as well. So again, this is really, Lee syndrome is really kind of a final common phenotypic pathway for many, many different types of mitochondrial pathology. So with that as an introduction, and sort of a way to ground us in this question of phenotypic correlates of mitochondrial disease versus genetic mechanisms, we're now really going to jump into the genetic mechanisms related to mitochondrial DNA. So mitochondrial DNA, as I think almost everyone on this call knows, has some really special characteristics that are quite different from nuclear DNA. So the average cell has thousands of copies of mitochondrial DNA. Some cells have hundreds of thousands of copies. So that leads to the unique mechanisms of heteroplasmy as opposed to just homozygous and heterozygous genetic changes with nuclear DNA. In addition to that, mitochondrial DNA is polycistronic. There's no splicing associated with mitochondrial DNA. It has a circular structure and just a single chromosome, as opposed to the multiple chromosomes of nuclear DNA. So all of those components of or characteristics of mitochondrial DNA are going to be relevant to the mechanisms that we're going to talk about. So going back to our initial discussion of Lee syndrome, so the single mutation that is responsible for the highest number of patients with Lee syndrome is a mutation at the position 8993 within the mitochondrial genome. So that falls within the gene ATP6 that encodes complex 5 of the oxidative phosphorylation pathway. So there are two different mutations that can occur at this position. There is a T to G change and then a T to C change. This is a really nice way to discuss the topic of heteroplasmy and how the degree of heteroplasmy relates to the clinical severity of the phenotype in the mtDNA variants. So 8993 T to G is more common and more severe than the T to C genetic change. So patients with high heteroplasmy for T to G are quite likely to have Lee syndrome and other severe CNS manifestations of mitochondrial disease. Patients with heteroplasmy of less than 50% are generally asymptomatic, and patients that are in between often have a phenotype called NARP that we'll talk about in more detail later. The two graphs that you see here are a curve of the probability of a severe outcome, and by severe outcome, that means CNS injury that causes significant symptoms. And on the x-axis, that is the heteroplasmy of an individual. For this particular mutation, you'll notice that there's not a discussion of which tissue the heteroplasmy is in. And that's because the 8993 mutations in particular, but more generally ATP6 mutations, don't tend to have a lot of variability across different tissues. And that's in contrast to some other mtDNA pathogenic variants. So an individual that has an 8993 T to G mutation at 95% in a muscle biopsy, it will probably be close to 95% in blood or in buccal sample or urine sediment as well. So comparing these two curves, you can see that an individual with higher heteroplasmy, let's say 75%, is much more likely to be asymptomatic if they have the T to C mutation as opposed to the T to G mutation. Those patients with moderate heteroplasmy are less likely to have the Lee syndrome phenotype, and they're more likely to have a phenotype called NARP, which stands for neurogenic weakness, which is associated with peripheral neuropathy, ataxia, related to cerebellar dysfunction, as well as peripheral neuropathy, and retinitis pigmentosa. So this picture in the upper right is a fundoscopic image, and you can see the optic nerve, you can see the fovea at the center of the image, and then in the periphery, you can see all this dark brown or black pigment, which is not typically present, and that's characteristic of retinitis pigmentosa, which is a progressive process where you lose, in particular, function of the rods, the photoreceptor cells that are responsible for night vision and peripheral vision. So a lot of these patients will say, initially they feel like they always need to have a flashlight with them or a headlamp, or they always want to have the lights on in the house. They'll also find that they are tripping and falling, and that is this really unfortunate combination of cerebellar dysfunction, peripheral neuropathy, and loss of peripheral vision. If you lose any one of those things, you can kind of make up for it with the others, but losing all three at the same time puts people at very high risk of falls and of injury related to falls. Along with the ataxia, there's often some progressive learning difficulties, which are often the first symptoms and show up in childhood. The retinitis pigmentosa, as I mentioned, is progressive. The weakness related to peripheral neuropathy is also progressive, and that eventually will result in an inability to be ambulatory. What shows up initially as learning difficulties in childhood progresses to dementia and cognitive decline in adulthood. Some of the diagnostic studies that can be used include nerve conduction velocity that look at peripheral nerves. In the lower right here, this is an MRI image. This is a sagittal section through the middle of the cerebellum. And what I'm showing here is that there's the fovea of the cerebellum are too prominent, and you can see too much CSF around those fovea, and that indicates cerebellar atrophy, which is the imaging correlate of cerebellar ataxia that patients experience. There are other, as with most of the mitochondrial phenotypes that we'll talk about, there are other genetic correlates of these phenotypes, but the 8993 T to G mutation is found in at least half of patients that have the classic NARP phenotype. I'm going to move on now to the single most common pathogenic mtDNA variant. And this is something that most of you probably have seen in clinic and certainly have read about. We're talking about MELAS, which stands for mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. So MELAS is a really characteristic phenotype, and it has a specific brain MRI finding. So on the right of the slide here, you can see that this patient has T2 hyperintensity across the full thickness of the occipital cortex, but that it's asymmetrical and unilateral, and that it also doesn't correlate with a vascular distribution. So that's really characteristic of the acute injuries that can be seen for patients with the 3243 pathogenic variant. Both the asymmetry, the occipital predominance, the fact that it impacts the cortex and kind of full thickness of the cortex. All of those things are neuroradiologic correlates that can help you to distinguish maybe from Pol G, which we'll talk about later, that has some subtly different brain MRI findings. So of the patients that have these stroke-like episodes with this brain MRI correlate in conjunction with lactic acidosis, about 80% of them are found to have the 3243 A to G pathogenic variant. That's present in the tRNA leucine within mitochondrial DNA. But importantly, most people with 3243 A to G do not have MELAS. So MELAS is one very well described and sort of historically important phenotype that's associated with this point mutation, but it's by no means the only clinical correlate with that mutation. And we also know that there are a lot of people, this is a very, very common variant. So if you look at the NOMAD database, I believe it's between 1 in 5,000 and 1 in 10,000 people in NOMAD who should, for the most part, should have been excluded if they have really overt or severe symptoms, have the 3243 A to G variant. So it is quite common. If you start looking for it in places like atypical diabetes or hearing loss clinics, you'll start to find it a lot. For patients that have the classic phenotype, the typical onset is in childhood with developmental delays. Patients often have headaches, so sometimes severe migraines is a really significant aspect of the phenotype. A lot of patients have short stature and are very underweight. I think there's an emerging story around the regulation of appetite and body weight as it relates to specific mechanisms of mitochondrial disease. So there's a biomarker that Dr. Falk likely talked about called GDF15. GDF15 is not elevated across all mitochondrial diseases, but for patients with 3243 variants, and particularly those that have it at higher heteroplasmy, GDF15 tends to be quite elevated. And we also know that GDF15 is a direct regulator of appetite. So one of the things that I struggle with the most in managing patients with 3243 in clinic is figuring out what the right approach to nutrition is. Is it a G tube? But for the more severely affected patients, lack of appetite and almost cachexia, really severely low BMI, is a really common part of the phenotype. Patients will have exercise intolerance and weakness. Some of the more severe patients will present with seizures. Cardiomyopathy and arrhythmia is relatively common in 3243. Diabetes and renal disease. We just had a patient that came to our clinic with end-stage renal disease. She's listed for kidney transplant, and it turns out that the mechanism of that for her is the presence of the 3243 variant. So that was her presenting feature, was renal failure. We have worked with the adult endocrinology group here on our campus, and we diagnose several patients a year in the endocrinology clinic who have a diabetes presentation. They seem to need some insulin, but they're negative for all the autoantibodies that are associated with type 1 diabetes. They're also underweight and small, so they really don't fit the typical profile of someone with type 2 diabetes. And we've worked with the endocrinology group here to do mtDNA testing in that scenario. And it's a pretty high yield place to identify the 3243 variant. Some biomarkers and other correlates with the 3243 variant. This is one, as opposed to 8993 and other ATP6 variants, where there really is dramatic variation across tissues. And I'll talk about that a little bit more on the next slide. Patients that have the kind of classic diagnostic pathway with a muscle biopsy and histology might have this appearance here, the ragged red fibers that was one of the classic biomarkers for mitochondrial disease. These patients would have, if you did enzymology to look at the function of mitochondria in the muscle tissue, you would find that they're low on complex 1, 3, and 4. The reason that complex 2 is not low is because this is within the tRNA for leucine, so this is a mitochondrial translational defect. It specifically affects the ability of the mitochondria to translate proteins from the mitochondrial DNA, but the nuclear DNA is not affected. So complex 2, which has exclusively nuclear encoded subunits, should have normal or even high activity in an individual with MELAS or other mitochondrial translational defects. These patients, lactate actually does tend to be a good biomarker, unlike a lot of mitochondrial diseases where lactate is not a good biomarker. For MELAS, it does tend to be. That can be elevated in blood, although a peripheral phlebotomy lactate can be very hard to interpret. Elevation in CSF lactate is much more specific. So if this patient's getting an LP and someone thinks to measure lactate or to do that on MRS, that can be an important phenotypic correlate. Some of the MRI changes that we see in addition to the classic MELAS stroke-like episodes are basal ganglia calcifications. We have several pediatric patients that have presented this way. They have some symptoms, developmental delay, seizures. Someone does either an MRI or CT imaging, and they see extensive basal ganglia calcifications. That can be a pretty specific phenotype associated with 3243. So the topic of heteroplasmy is a really interesting one for 3243. So this is a paper that came out a few years ago looking at the heteroplasmy for the 3243 A to G variant, both within individuals across time and also across different tissues. So the takeaways from this paper are that blood heteroplasmy for the 3243 variant drops with age, and that is a competitive selective process within the hematopoietic precursors. So those precursors within the bone marrow are constantly churning out leukocytes to get into the peripheral circulation. Those hematopoietic precursors that have better mitochondrial function are going to be more successful at making white blood cells to make it into the periphery. And over the decades, as you age, that competitive process leads to lower and lower measured heteroplasmy within the cells that you get in a blood sample. So for many patients, particularly patients with higher heteroplasmy to begin with, the heteroplasmy can drop significantly with age. So the interpretation of whether the 3243 A to G variant at a particular level of heteroplasmy could be associated with the clinical symptoms that you're seeing, that can be a really nuanced thing to tease out. And you have to take this phenomenon into account. So if you find in a 70-year-old with hearing loss and diabetes that they have 3% heteroplasmy in blood for the 3243 variant, I would say that's very likely a contributor because they would have had a much, much higher heteroplasmy at an earlier age. We see a little bit less of that selective pressure within other tissues, such as urine and muscle. But the 3243 variant is usually not like the deletion, which we'll talk about, where it can be cleared completely from blood or buccal samples. So particularly now that we tend to do buccal samples pretty often as our approach to genetic testing, as long as you have that idea in your mind that the buccal sample is going to be significantly less both than that person was earlier in life and much less than the heteroplasmy would be measured in a muscle sample, that's a really good way to go about testing. Again, as long as you keep this dynamic in mind and apply that correction factor to whatever the heteroplasmy is that you find. There are some accepted treatments for MELAS, and the accepted and kind of relatively evidence-based treatment for MELAS is to give arginine, particularly in the setting of an acute stroke-like episode, but most people would also do that chronically as a preventative measure to prevent stroke-like episodes. The idea there is that arginine can participate in nitric oxide synthesis, and nitric oxide is a mediator of vascular relaxation. So you can get better cerebral perfusion in someone if you're giving them arginine. And in the setting of an acute stroke-like episode, you can rescue some of the damaged tissue by bringing someone into the hospital, giving them IV arginine along with other physiologic support while they recover from the stroke-like episode. For me, on an outpatient basis, I use citrulline. So there are a couple of studies now showing that you get more of an effect of nitric oxide synthesis with citrulline as opposed to arginine, probably mostly because of the arginase enzyme that's present in the intestines. So by giving citrulline, you're not subject to that arginase phenomenon in the intestines, and you have higher bioavailability. There's currently some ongoing clinical trials trying to find the right dose for citrulline. But I should say most people get pretty high doses. I would say a commonly accepted dose would be 10 grams per day, which might sound pretty high to people that are thinking about urea cycle defects. But there are ongoing clinical trials to see if maybe the dose should be 2 or even 4 times as high as that. MRF is the other of the 3 really common mtDNA-mediated diseases, in addition to 8993 and 3243. So MRF is the most common clinical correlate with the 8344 A to G mitochondrial mutation, which is as common, almost as common as the 3243 variant in population databases. There are many overlapping features between MELAS and MRF, but patients with MRF, for one thing, they really characteristically get these lipomas at the base of the neck. So the explanation that I've heard for why the lipoma occurs right here, and it's always in the same spot in every patient, it's right at the base of the neck, top of the shoulders, is that is the last place in the body that has brown fat tissue. And so brown fat is this really specialized tissue that's responsible just for thermogenesis. So unlike white fat, which is responsible for storing triglycerides and having a long-term source of energy for the body. Brown fat is responsible for thermogenesis. So it's has uncoupled mitochondria with feudal cycling, just with the goal of heat production. And something about the interaction between that tissue and the presence of the 8344 A to G variant leads to this proliferation at that spot. So this is very, very characteristic of MRF and a few other mtDNA point mutations. Patients with MELAS are much more likely to have stroke-like episodes, although people with 8344 variant can have it. People with 3243 are much more likely to have diabetes, migraines, growth failure, renal disease, and cardiomyopathy. People with 8344 more likely to have ataxia, myoclonus, seizures, and lipomas. So there's a really nice study that was published now 10 years ago, looking at the overall burden of symptoms in individuals with the 8344 variant, and finding that there's pretty high prevalence of mild kind of ongoing muscle breakdown or increased CK, pretty high prevalence of muscle weakness, seizures, ataxia, myoclonus, a little bit lower prevalence of heart disease. But as a result of this survey of the symptom burden in adult individuals with this genetic change, this is a set of guidelines that I tend to follow when I see these patients in terms of checking labs, making sure that they're getting regular cardiology evaluations, making sure that we're thinking about sleep studies and respiratory weakness, swallowing function, endocrine function, checking for hearing loss, checking for psychiatric comorbidities, which are quite common as well, and checking for cognitive decline. So a phenotype associated with lower heteroplasmy, in particular for the 3243 variant, is called MIDD, maternally inherited diabetes and deafness. So for folks, this is a publication in the lower left showing that for folks with the 3243 point mutation, 80% of them will have diabetes by age 60. So this is really an age-dependent phenomenon. It's incredibly rare for people to have diabetes in childhood. So we probably don't need to have really intensive monitoring for the onset of diabetes. But starting at age 20, early 20s, there's a pretty steep rise in the prevalence of diabetes for people with 3243 to the point where, the majority of people have diabetes by age 40. And there's very clearly an indication for ongoing screening and monitoring for the onset of diabetes. I'm going to skip this one in the interest of time. And this. Another mtDNA-based phenotype that you will come across quite a bit is called Leber's hereditary optic neuropathy. That is a description of a phenotype in which an individual will have bilateral subacute loss of central vision, very commonly but not exclusively in young adult males. And it is caused by homozygous mutations in complex 1 encoding genes. The most common one is 11778G to A, which is in the mtDNA encoded ND4 subunit of complex 1. And the pathophysiology here is that the mitochondrial dysfunction leads to cell death of the retinal ganglion cells and hence the optic nerve. Now, LHON can be a really challenging finding when it comes up on mtDNA sequencing, especially if you weren't looking for it. So it turns out that the prevalence of these variants, in particular 11778G to A, is quite high in the population, and the penetrance is quite a bit lower than we thought it was initially. So for some of the LHON variants, the penetrance can be as low as like 5% or even less. And so it can be challenging to counsel people who have one of these findings that come up on mtDNA sequencing. This is a really interesting kind of natural experiment for us to understand gene by environment interactions. So it is quite clear that these variants become more penetrant in the setting of smoking, in the setting of heavy alcohol consumption, in the setting of occupational level exposures to pesticides. All of those things have been found to increase the penetrance of these genetic changes. There's also a really interesting study looking at two populations, one that lives at like 10,000 feet of elevation in Tibet, and a different part of that same population that live at low elevation. And it turns out that the people who live at low elevation have higher penetrance for LHON or for a particular LHON variant. So that could lend credence to the kind of oxidative stress type mechanism that people invoke as a potential correlate for this disease. Lastly, I'll mention that it is also pretty clear that there is an interaction between these point mutations in mtDNA and the background haplogroup upon which that point mutation is overlaid. So there are certain haplogroups or ancestral DNA, ancestral mtDNA haplogroups where the LHON variants are more penetrant than others. So a lot of really interesting gene by gene and gene by environment type information to learn about mechanisms of mitochondrial disease from LHON. Kern-Serre syndrome and CPEO are a spectrum. The spectrum of disease associated with a single deletion of mtDNA. The typical size of the deletion is 4,977 base pairs. However, there are variable sizes of that deletion. And it seems like, to a first approximation, any size of deletion will act relatively similarly in terms of causing this, this clinical correlate. 95 or 96% of the time, this is a de novo finding, which is quite different than some other genetic changes that we've talked about. So for example, 3243 and 8344, if we identify that in a child with neurologic symptoms, it's quite common that we find that it's inherited from a mother that has lower heteroplasmy or some other reason for reduced penetrance. The kind of middle ground is the ATP6 variants, like the 8993 T to C and T to G variants that we talked about. Both of those tend to be inherited about 50% of the time, and they tend to be de novo about 50% of the time when we find them in a proband. The single deletion is at the other end of the spectrum. So it seems like the mtDNA, there is a purifying process in making an oocyte that means that the single deletion of mtDNA is very unlikely to make it through the germline. So this is almost always, but not 100% of the time, a de novo finding when we do identify a single deletion. The mild end of the spectrum of disease associated with the single deletion of mtDNA is CPEO, or chronic progressive external ophthalmoplegia. And you can see some images on the right that demonstrate that finding. So individuals have ptosis, and they also progressively lose extraocular movements, particularly abduction of the eyes. And so when I see an individual in clinic, there's a very characteristic kind of subjective impression that I have that they're moving their head instead of moving their eyes. So where it would be intuitive for me to kind of move my eyes to look in another direction, they move their whole head. So that seems to be, in my experience, a fairly specific subjective finding. A more severe manifestation of disease associated with a single deletion of mtDNA is called Kern-Serre, which is childhood onset of this exact same finding. And in addition to that, intellectual disability, ataxia, dysphagia, hearing loss, weakness, exercise intolerance, arrhythmia. The arrhythmias are really, really prominent in Kern-Serre, to the point where the vast majority of patients have a pacemaker by the time that they are young adults. Many of them will have symptomatic third-degree heart block, and that will be the indication for a pacemaker placement. They also have very high GDF-15 levels and also have a lot of difficulty with appetite and with low body weight and kind of cachexia and anorexia. These patients also get retinitis pigmentosa. So Kern-Serre is almost like it's all the phenotypes that we've been talking about up till now in a single disease. CPEO plus is a descriptor where someone has CPEO plus at least one other symptom, but not all of the manifestations of Kern-Serre. The most severe end of the spectrum related to a single mtDNA deletion is called Pearson syndrome. So Pearson syndrome is when the deletion is present at high enough heteroplasmy that it is impacting blood cell formation and causing anemia. So the other thing that tends to be seen at the most severe end of the spectrum is exocrine pancreas dysfunction. And we've also seen patients present with liver failure in this scenario of high heteroplasmy for a single mtDNA deletion. The anemia for these patients is severe enough that they require recurrent blood transfusions. However, if you continue to do transfusions, those patients can grow out of the stage at which they have hematologic manifestations related to the single deletion. And it's that same process that we talked about earlier as being the reason that heteroplasmy in peripheral blood is not always a reliable indicator of heteroplasmy elsewhere in the body, because the hematopoietic precursors that are making peripheral blood cells are constantly under this selective pressure to have better and better mitochondrial function. So for the single deletion in particular, if you have a specific suspicion for the single deletion, I think it's still worth trying to do mtDNA on a buccal swab. But if you don't find it on a buccal swab and you still have a patient with a very specific phenotype that's compatible with Kern-Serre or CPEO, you might want to consider doing a muscle biopsy for mtDNA sequencing. All right, we are halfway through the talk here, and we're going to move on from mtDNA variants to nuclear DNA variants. So I want to pause here for a minute and see if anyone has questions about the mtDNA related conditions that we talked about.
Nothing came up in the chat.
Okay, thanks, Pete.
Yep.
All right, we'll move on to nuclear DNA mutations. So we'll start with nuclear genes that encode subunits of the respiratory chain complexes. So complex 2 genes are quite interesting. We talked about the clue that you can get from mitochondrial enzymology in tissue. If you find that complex 2 is normal or high and 1, 3, and 4 are low, that would indicate to you that your mitochondrial dysfunction localizes to a mitochondrial translational defect. So complex 2 has the unique characteristic of being the only subunit that has exclusively nuclear encoded components. So The components of complex 2 are SDHA, B, C, and D. And there are also a couple of nuclear encoded assembly factors, SDHAF1 and MAX. And the really interesting thing about complex 2 is that there is a phenotype for heterozygotes, and it is cancer predisposition. So this image that you see is an individual with a paraganglioma. So this is a person with a growth on the side of the neck. And this is particularly true of people with SDHB. They have a really significant predisposition to these tumors. So there's a couple things going on here, thinking about this mechanism. There is likely a second hit within the tumor cells where they have lost function. But then the question comes up of why does mitochondrial dysfunction lead to cancer predisposition? And the thought is that that tissue, that stress within the tissue leads those cells to secrete growth factors that then lead to unregulated cell proliferation and ultimately malignant transformation. So that's the link, and that mechanism is pretty well worked out in terms of something called HIF, or hypoxia-induced factor. This also, these genes also can result in classic mitochondrial phenotypes like Lee syndrome and other kind of multisystemic severe mitochondrial disease if there's a constitutional inheritance of biallelic variants. In particular, we tend to see that with SDHA because SDHA is the least penetrant for the cancer predisposition. So a lot of people don't know that they are carriers of SDHA. And so I have a couple kids in our clinic that have biallelic SDHA variants and have associated neurologic disease. Moving on to complex 3, I wanted to highlight a topic here that the components of the respiratory chain are not acting in isolation. So UQCRC2 is a gene that encodes a subunit of complex 3. Patients with biallelic mutations in UQCRC2 tend to look more like individuals with kind of classic disorders of intermediary metabolism than they do mitochondrial patients. So these patients tend to have recurrent and acute severe hypoglycemia, hyperammonemia, and lactic acidosis, decompensating with acute illnesses, responding really well to anabolism and IV fluids. And it's likely that what we're seeing here is that this is a manifestation of the supercomplexes of enzymes that are present within the mitochondrial matrix. So complex 2 is not just part of the respiratory chain, but it's also complexed with enzymes involved in fatty acid oxidation and gluconeogenesis and other processes like that that are more kind of classic intermediary metabolism pathways. And so this is a rare disease, but one that has a really strikingly different phenotype than a lot of mitochondrial diseases. What I'm showing you here on the right is a functional study called Blue Native Page that is done by my colleague Johan van Hove. This is a patient with UQCRC2, and you can see in his muscle tissue that there's no band right here associated with complex 3. So there's no stable complex 3 for this patient, and that's the basis of his symptoms. SIRF1 is a nuclear encoded gene that is necessary for complex 4 assembly. It is one of the most common single causes of Lee syndrome, and it accounts for a lot of patients with complex 4 deficiency associated Lee syndrome. There are some characteristic aspects of the phenotype that are a little bit different from other patients with Lee syndrome. So patients with SIRF1 tend to have hypertrichosis. They also are at very, very high risk of central apnea and respiratory failure. And a lot of these patients end up with tracheostomies. This is also a disease that tends to just kind of have more of a slow progression and less of the really acute neurologic injury with a severe decrement in function associated with a single episode of illness, the way that you might see with like a 8993 T to G patient. So the SURF1 tends to just kind of be a little bit more of a slow progression, but with the really high risk of respiratory failure and growth failure as well associated with it. In addition to autosomal nuclear mitochondrial disorders, there are X-linked nuclear mitochondrial disorders. One that has come up in our clinic and has been really interesting to think through is NDUF-B11. So NDUF-B11 is a nuclear encoded complex 1 subunit on the X chromosome, and it has very different presentations in men and women, or boys and girls. So girls can have this phenotype that looks a lot almost like incontinentia pigmenti, to name another X-linked dominant condition. So they can have these linear skin defects that follow the lines of Blaschko. They can also have microphthalmia, or kind of focal developmental eye defects. And then women with NDUF-B11 are also at very high risk of cardiomyopathies and arrhythmia. So throughout the body, you're seeing manifestations within the tissues that are expressing the mutated copy of NDUF-B11, whereas where the lionization is more favorable, these patients have normal mitochondrial function and they don't have tissue damage in those areas. The boys that have NDUF-B11 generally are not viable, or if they are born, they tend to die of severe neonatal lactic acidosis very, very early in life. So the pyruvate dehydrogenase complex is a really interesting topic to talk about. So the PDH is a large multi-subunit enzyme complex in the mitochondrial matrix that is the link between glycolysis and the TCA cycle. So when you consume carbohydrates, they enter into the glycolytic pathway, ending with pyruvate. Pyruvate dehydrogenase then makes acetyl-CoA out of pyruvate, and the acetyl-CoA can participate in the TCA cycle. If there's a block at the level of pyruvate dehydrogenase, that pyruvate is going to get shunted into lactate and alanine, both of which are in equilibrium with pyruvate. So those are the primary metabolites that can indicate a concern for pyruvate dehydrogenase deficiency. If you measure both pyruvate and lactate, then you'll see a high pyruvate to lactate ratio as a potential indicator of pyruvate dehydrogenase deficiency. You also see very high levels of alanine. Alanine can be a little bit difficult to interpret in isolation because the levels of each amino acid are related to the duration of fasting. However, if you benchmark alanine to lysine or leucine, and you look for an alanine that's more than 5 times the level of lysine or leucine, that can start to be pretty specific for a patient with a chronic lactic acidosis. And pyruvate dehydrogenase deficiency is one of the more common causes of that. There are a couple papers by Jerry Bedoyan showing that you can identify that signature in newborn screen blood spots and potentially could identify pyruvate dehydrogenase deficiency from the data that we already gather for newborn screening. So this is a very large and complex enzymatic complex with 13 genes that are contributing either to the subunits of the enzyme complex or to the regulators of it. By far, the most common genetic cause of pyruvate dehydrogenase deficiency is the gene PDHA1, which is X-linked, and that encodes the E1 alpha subunit of the complex. So, because this is X-linked, we see very different presentations in males than in females, and a very different profile of specific types of mutations that are present in that gene. So boys that survive, that are viable with PDHA1 related conditions, have hypomorphic mutations. So those are almost always missense changes, and they have significant residual enzyme activity. But for those boys, they have decreased enzyme activity throughout the body. So every tissue has the same amount of decreased enzyme activity. So those boys can have really significant lactic acidosis. Clinically, they present with ataxia, hypotonia, developmental delay. This is one of the pathways that can lead to the Lee-like phenotype on brain MRI, but you don't tend to see structural lesions, which is in contrast to females, which we'll talk about in a minute. These patients can have a severely elevated lactate, but with a low to normal lactate to pyruvate ratio. Another way to express that is that the pyruvate is relatively more elevated than the lactate, but both are significantly elevated. You can do PDH enzyme activity. It used to be available in leukocytes. I think it may only be available in fibroblasts now. I know Dr. Van Hove does that in the lab here. More typically, we're diagnosing this with sequencing, with genetic testing. And the treatment for this disorder is really interesting. So first of all, thiamine is a cofactor for the enzyme complex, and there are pretty clear genotype-phenotype correlations for missense changes that respond to thiamine. So can't remember if they still do this, but the old version of the enzyme assay, they would do it in two settings. They would do it both with and without thiamine. And that was a way to just kind of functionally in the lab to characterize which missense changes do or don't respond to thiamine as a cofactor, and to giving supraphysiologic levels of thiamine to induce additional activity of the enzyme complex. Another way that is pretty intuitive in terms of treatment is to consider ketogenic diet for these patients. So we talked about pyruvate dehydrogenase as being the linker between glycolysis and the TCA cycle. So if you could feed substrate into the TCA cycle without needing glycolysis, you can just bypass the pyruvate dehydrogenase enzyme complex. So the way to do that is to use a ketogenic diet. So if you get all of your energetic needs met from fatty acid oxidation, you're in a state of ketosis. Those ketones go to the brain. They provide an alternative energetic substrate that doesn't need to go through the pyruvate dehydrogenase enzyme complex. This very clearly works to reduce lactate levels. It's a little bit less clear, but I think there's pretty strong circumstantial evidence that it does improve developmental outcomes and neurologic symptoms to have patients with PDH on a ketogenic diet. There's also a drug called dichloroacetate, which affects the regulators of pyruvate dehydrogenase and just kind of moves the enzyme into the on position. So it's just kind of constitutively on, as opposed to this really tightly regulated enzyme that sometimes is off, sometimes is on, depending on cellular conditions. So there is a clinical trial that has been completed and is in the analysis stage right now, assessing whether putting patients with pyruvate dehydrogenase on dichloroacetate leads to clinical improvement in addition to biochemical improvement. So we should find out about that pretty soon. Girls with pyruvate dehydrogenase deficiency have very, very different phenotype. So girls have a different mutational spectrum. So the girls that have mutations that are compatible with viability for boys tend to be pretty much asymptomatic. The girls that are symptomatic typically have nonsense, not all of them, but a lot of them have nonsense or complete null alleles that would not be compatible with life for boys. So we tend to see different mutations in those two populations. The girls with null alleles have specific tissue damage in the areas where the mutated allele is expressed. The place that we see that is in the brain, and it happens very, very early in development, to the point where it looks like a congenital brain malformation. So one of the classic congenital brain malformations associated with PDHA1 in girls is agenesis of the corpus callosum. Another thing that you can see is asymmetrical kind of cystic lesions or generalized atrophy. Girls with PDHA1, because of the different formation and structure of the brain during fetal and embryological development, they tend to have some kind of subtle but noticeable dysmorphic facial features. Girls are pretty unlikely to have a significant lactic acidosis in terms of clinically significant. It certainly can be measurable. And it turns out, like looking at the newborn screen data, you can often pick out the girls with PDHA1 on the basis of the alanine ratios. But it's unlikely to result in an acidosis that would cause arrhythmias or cause failure to thrive or something like that in and of itself, because the girls just have enough pyruvate dehydrogenase enzyme activity elsewhere in the body that they are metabolizing lactate. They are clearing lactate from the circulation, and it's not just building up chronically like the boys are. So the girls that are more or less symptomatic, it's not a question so much of the residual enzyme activity associated with the specific mutation that they have. The more determining factor is what the pattern is of lionization or exon activation in the brain. And so on the mild end of the spectrum, girls that have that are mostly expressing the working copy of PDHA1 can have pretty mild clinical symptoms. On the opposite end of the spectrum, girls that have unfortunate exon activation within the brain can have severe congenital brain malformations and really, really profound neurologic symptoms and everything in between. There's a lot of nuclear DNA encoded genes that are responsible for the maintenance and replication of mitochondrial DNA. So the most important one to talk about is POLG. So this is a very, very common mitochondrial disease. So any mitochondrial clinic in the country will follow a significant number of patients with POLG related disease. The most severe end of the spectrum associated with POLG is called Alpers syndrome. Alpers syndrome is typically characterized by normal early development or mild developmental delay. But then with the onset of seizures in early childhood, maybe around 1, 2, 3 years of age, and characteristically, it tends to be EPC, or epilepsia partialis continua, which is status epilepticus for focal seizures. These seizures are often very, very refractory to treatment and almost impossible to treat with typical anti-epileptics. In the past, we don't really see this very much anymore, but in the past, patients would get valproic acid or Depakote. And in the setting of POLG mutations, Depakote can precipitate liver failure. So the classic description of Alpers syndrome is onset of difficult to treat focal epilepsy plus liver failure. We don't see that association as often now in the setting of much more careful use of valproic acid in the seizure types that can be correlated with POLG. So most child neurologists are pretty clued into the idea that in an appropriate clinical setting, you have to rule out POLG before you use Depakote. Now, patients with POLG can still have some liver disease, but in the absence of getting Depakote, it doesn't tend to be like a really fulminant and presenting feature of the disease, although occasionally it can be. The prognosis associated with Alport syndrome is very poor. Most patients die within months to years after the onset of symptoms. The diagnostic studies are characteristic of mitochondrial translational defects. So POLG, polymerase gamma, is the enzyme responsible for replication of mtDNA. So in the absence of POLG, you have declining amounts of mtDNA in each cell. And as a result, you have decreased translation of mtDNA encoded proteins. And so you see this characteristic decline in complex 1, 3, and 4 activity, just like we saw with 3243 or 8344. Another functional study that you can do is to look for depletion in the total quantity of mtDNA, which you can see in muscle and liver. One thing to caution you about is that deconditioning is associated with mitochondrial dysfunction. So if you're working up a patient who is not ambulatory or is has significantly decreased physical activity, you do a muscle biopsy of the leg, it would be normal for that person in the absence of POLG or another mtDNA depletion disorder to have maybe 50% of the normal amount of mtDNA. So you always have to interpret that in the context of the amount of physical activity that the patient is doing. There's a lot of other clinical correlates with POLG. Later onset POLG conditions look very similar to some of the other components of the mtDNA replisome. That includes a gene called Twinkle and another gene called RRM2B. Together, the three of them are the most common genes that are seen in adults with mtDNA depletion disorders. There are a few POLG variants that have a dominant mechanism. And so this is a question that comes up a lot. So if you do genetic testing, like if you do an epilepsy panel, POLG is a really common disease. There's a lot of carriers for POLG. And so the report will come back that the patient has a single POLG variant. And then in that same table from the testing company, it'll say that POLG is associated with dominant and recessive disease. And so this is the source of a lot of referrals to our clinic. And it's important to point out that those are different mutations in the gene. So the common carrier status is for recessive variants in POLG that do not have a dominant phenotype. The dominant POLG genes are much, much rarer, much lower in prevalence, and they're pretty well characterized. So if there's a VUS in POLG, while I can't be 100% certain that it's not a dominant variant, it's a lot more likely that it would have a recessive mechanism than a dominant mechanism. Patients with any of these three phenotypes, RRM2B, POLG, Twinkle, very often present with CPEO as the presenting symptom, ptosis, ophthalmoplegia. Patients with a little bit more severe disease develop neuropathy and ataxia, and they also get dysarthria along with their CPEO. Some patients will present with Parkinsonism, and one of the other biomarkers that you can look for, in addition to depletion of mtDNA and decrease in complex 1, 3, and 4 enzyme activity, one of the other things that you can see is if you sequence mtDNA, you could get a result where it shows multiple deletions of different sizes of mtDNA. That's different from a single deletion mediated disease. So those have different clinical implications, And so it's important if you see two or more different deletion sizes in your mtDNA sequencing report, you want to think about nuclear genes that maintain mtDNA, as opposed to if you get an mtDNA sequencing report that has a single deletion only, then you're thinking of that as the Kern-Serre CPEO spectrum. There is a really fascinating mitochondrial condition called MINGI, or thymidine phosphorylase deficiency. So thymidine phosphorylase is an enzyme that's responsible for maintaining the balance of the nucleoside pools that the genes like POLG and others are using as part of mtDNA replication. So if you have thymidine phosphorylase deficiency, you end up with a huge imbalance. You get a buildup of thymidine. You have much more thymidine as compared to the other bases available for mtDNA replication. And as a result, those enzymes are just constantly introducing errors into mtDNA. And as someone ages, they can get this characteristic clinical phenotype called MINGI, mitochondrial neurogastrointestinal encephalomyopathy. So this can have some things that are really similar to other disorders like ptosis, ophthalmoplegia, some brain MRI changes, hearing loss, peripheral neuropathy, all that kind of fits the script. The thing that's very different about MINGI is that you get severe gastrointestinal dysmotility, pseudo-obstruction. A lot of these patients are on TPN, and they're completely unable to feed enterally before they even get this diagnosis of MINGI. It is important to make the diagnosis early because this is a treatable condition. Either liver transplant or bone marrow transplant will restore enough thymidine phosphorylase activity in the body in order to rebalance the nucleoside pools and halt that process of progressive deterioration of the mtDNA throughout the body. CoQ10 synthesis disorders are an interesting group of disorders to talk about. So the role of CoQ10 in mitochondrial physiology is to act as a carrier of electrons, both from complex 2 to complex 3 and from complex 1 to complex 3. So in the absence or with a decrease in the concentration of CoQ10 in the body, you get a decline in the linked activity of complexes 2 and 3, which you can measure giving succinate and then measuring the product of that reaction. And there's some very interesting clinical correlates of CoQ10 synthesis disorders. So some of the one of the most common ones is CoQ8, which presents with ataxia, very specifically affects the cerebellum. But some of the others have more multisystemic and specifically renal manifestations. So CoQ2, PDSS, these genes can present with isolated renal disease. And some patients can have dramatic improvement in their renal disease, including one patient that we follow in our clinic who presented with steroid-resistant nephrotic syndrome, massive proteinuria and resultant edema, and then having identified the mechanism of so that patient initially was treated with steroids. His nephrotic syndrome did not respond to steroids, unlike most patients that have nephrotic syndrome. He had genetic testing for rare causes of nephrotic syndrome, was found to have a CoQ10 synthesis defect. And with high dose CoQ10 supplementation, his nephrotic syndrome has resolved. So really satisfying condition to treat if you can identify it. It's very rare, but very important to identify and manage appropriately. The last group of conditions I want to talk about are disorders of mitochondrial dynamics and mitochondrial membranes. So the mitochondrial membranes have some really characteristic features that are different from other cell membranes and other organellar membranes. So the mitochondrial membranes are constantly fissioning and fusing with each other to meet the specific needs of the cell. So different parts of the cell, different cells in the body need the mitochondria to have different characteristics. So in some cells, they need to be more fragmented and diffuse. In other cells, they need to be more agglomerated. And so there's a whole set of mechanisms to alter the shape of mitochondria in accordance with the physiologic needs of that part of a cell. One of the common disorders in that category is called OPA1. So the OPA1 protein is necessary for mitochondrial fusion, for individual mitochondria to agglomerate together into the single network. When OPA1 is not functioning, the mitochondria are small, fragmented, and stationary, and they can't interact with cellular motors that move the mitochondria into different areas of the cell. So on the right, you can see an image of an OPA1 knockout cell as compared to a cell with normal OPA1 function. And you can see that the mitochondria are much, much more fragmented and diffuse as compared to this tight network of mitochondria around the nucleus in the cell with functioning OPA1. So the clinical correlate of that is optic neuropathy. So within the retina, the ganglion cells need to have ongoing maintenance of the mitochondria in the nucleus, but then the axon is pretty long. It goes all the way from the retina back to the occipital cortex of the brain. And so in order for those mitochondria to interact with the cellular motors that move them along the axon, they have to assume a very specific shape. If they're not able to assume that shape due to lack of OPA1 function, then you don't get mitochondrial function away from the cell body of the retinal ganglion cells, and you get death of the axons, which manifests as optic neuropathy and vision loss. A minority of patients with more severe loss of OPA1 activity can have ataxia, developmental delay, and myopathy. The last genetic mitochondrial disease to talk about is Barth syndrome. So I mentioned that the mitochondrial membrane has really characteristic and specific composition that's different from other membranes in the body. That's particularly true of the inner mitochondrial membrane. So the inner mitochondrial membrane has this very tightly folded appearance where the membrane folds kind of lay on top of each other. And that configuration is necessary for optimal function of the electron transport chain and oxidative phosphorylation. So the enzymes that are participating in electron transport and oxidative phosphorylation are concentrated in the sharp folds of the inner mitochondrial membrane. And the membrane can only achieve those sharp folds with a substance called cardiolipin, which is kind of a unique lipid species in the body. And there's an enzyme called tafazin, encoded by a gene called Taz, which is necessary for the synthesis of cardiolipin. The inability to synthesize cardiolipin leads to dysfunction of the inner mitochondrial membrane, and the clinical correlates of that mechanism are left ventricular non-compaction, cardiomyopathy, neutropenia, and skeletal myopathy and poor growth. This tends to be almost exclusively present in boys because it's an X-linked recessive disorder. And it has a biomarker that is pretty specific in association with it called 3-methylgluconic acid. So for reasons that I don't know off the top of my head, the dysfunction of the mitochondrial membrane leads to this secondary inhibition of the pathway, and you get accumulation of 3-methylgluconic acid. So the elevated 3-methylgluconic acid is true not just of Barth syndrome, but also I would say 10 or 12 other disorders that are specifically affecting mitochondrial membrane function. All right. So that is the end of my talk. Thank you all for listening for the last 90 minutes. And I'm happy to take questions or have a discussion about any of these topics.
Thanks, Austin. That was great. Questions for Dr. Larson?
Hey, Dr. Larson, this is Jessie Priestley in Grand Rapids, Michigan. How are you?
Good. How are you, Jesse?
Good. I will be caring for a teenager boy with mosaic PDHA1 and am struggling with what to do with him. Do you typically give your boys who are more mildly affected like an emergency letter or precautions for dextrose administration or anything like that?
Yeah, it's a really good question. It's something that I struggle with a lot. So, is it a null mutation or is it a missense variant?
I think it's a missense variant, but it's
So,
pathogenic.
yeah, so in the setting of the potential for residual enzyme function, I think there's more of a case for ketogenic diet. And I think there's also more of a case for more aggressive emergency management, because I think that there is more of a likelihood that there is brain tissue that is not irreversibly damaged in early development, but is vulnerable on an ongoing basis to stressors. So, the thing that I always struggle with is for girls with null alleles that clearly have, developmental brain malformations, like how much salvageable tissue is there if you were to invoke any treatment for PDHA1. For boys that have hypomorphic alleles, that's the opposite end of the spectrum. If it's a hypomorphic allele throughout the body, that's a pretty easy call. Those patients, I think, really do benefit from ketogenic diet and more aggressive management of acute illness. So the scenario you're talking about is kind of in between those two. And so I don't have a great answer for you other than it'll be a judgment call around, which tissues you think might be vulnerable but not irreversibly injured.
Yeah, he's pretty mild. Like he doesn't have a seizure history. This was like picked up on exome for I think developmental delays. So
What does his brain
it's
MRI
like
look like?
I think it looks I think we have yet to do one because this was like a
Okay.
oh.
Yeah.
I didn't
Look,
diagnose him, so he'll be seeing me shortly for the first time. So I have a hard time justifying
yeah,
like a ketogenic diet for this kid.
right.
I think thiamine sounds like a great idea. I
Yeah.
hope that DCA will be an option
Yeah.
down the road, but yeah, it's like a weird. He
Yeah.
seems
So I
to
would
do
say,
good.
yeah, thiamin's basically no risk at all. There's also pretty good data if it's a known pathogenic variant. There very well might be publications about whether it's thiamine responsive or not. We have, my colleagues and I have published some patients with reversible brain MRI lesions upon initiation of ketogenic diet. So, if there are any symptoms at all, I think it might be justifiable to do a brain MRI to kind of tease apart this question of, again, like vulnerable tissue at risk, but that hasn't been irreversibly injured versus irreversibly injured tissue. That's sort of how I think about how aggressively to manage PDHA1.
Cool, thanks. Good to see you.
You too.
And we're coming up on 1:30. Austin, I know you've got clinic to get to, so I think we will shut it down for today. We have Dr. Freeze come in next week to talk about CDGs. And thank you, Austin very much for presenting, and everybody have a good, safe weekend. Happy Veterans Day.
Thanks, everyone.